Hey, good morning, guys. It's me, Barry Miller, your CRNA for the day here at Dr. Miami's office. First case is on the table. It's going to be a simple breast dog. I'm going to use LMA general anesthesia. Let's watch. As you guys are well aware, I set up my airway management stuff the same time every time, except for this case. I add the LMA on top of all the other stuff just in case I have any problems. This is an LMA. All right, so the patient is on the table. I've applied the monitors, and let's get ready. I'm going to show you the IV insertion right now. All right, so in good preparation, I have everything laid out that I need. 20 gauge catheter, tape, gauze, alcohol, tourniquet on the arm, letting the blood vessels engorge. Okay, so look at this beautiful vein. It's just calling out my name. It's saying, "Barry, stick me, stick me." Oh, okay, I will. All right, using the Barry Miller technique, I use my thumb here to retract the skin and hold the vessel in place. That way it doesn't roll or move around. On the count of three. 1, 2, 3. Big pop, flash, withdraw, and advance. That's simple, guys. All right, so many people ask me why I don't pre-oxygenate most of my patients. They're young, they're healthy, no coexisting disease. I think the benefit-risk ratio isn't there. It scares people to have that mask go on their face, so I just have them pre-oxygenate by hyperventilation. Okay, there we go. Nice big deep breaths. Beautiful. Nice. Okay, so we're in position. I have the patient a little bit lower so that way I can control the airway a little bit better with this kind of technique and just wallow it in and then advance it like that real quickly. Inflate this, and there we go. LMA's in. We've got some humidification in there, symmetrical chest rise, and you can see the end tidal response here. That's good. Just a few minutes after induction here. Great vital signs. Doing well. I've got her on the ventilator just a little bit so I can get some things done, but I'll take her off of that. I'm going to back my SIVO off a little bit. There we go. So I wanted to show you guys this. This is her returning to spontaneous respirations. And what you'll see is these respiratory efforts are going to get larger and wider at the base, representing volume increase. All right, so here she is back to normal, breathing spontaneously on her own. You notice how it's higher and wider and much more rapid, which she's being stimulated right now. That'll calm down a little bit. So guys, this is Alex. Where are you going to school, Alex? FIU. FIU, what's your major?
Psychology.
Awesome. And what do you do here?
I'm a social media expert.
Yay! Thank you, welcome, happy Wednesday. So if you look at the time that I started the IV back in the feed, you'll see that she's got a great, huge antecubital vein. And somebody asked me why I didn't use that. Well, I like to use more distal veins. That way, if I miss, I can walk my IV insertions up the arm. Plus, if I'm having like a really bad day and I miss that big, juicy antecubital, in theory, distally now in the hand and arm is no good to me anymore because it'll infuse out of that puncture. All right, we're at the end of the case, and I'm going to extubate the patient deeply. You guys always ask me to show this, and right about now I am. I am at full surgical plane right here, and that's where I want to be. She's breathing spontaneously, and let's watch. Okay, so in preparation of that, I'm going to suction her airway out. All right, I've already released the tape, and now I'm just going to extubate her, and we'll go from there. You'll see. Okay, so let's do this, guys. Drop the pilot balloon. In one motion, I pull this out and put this one back in. Look at that, just like that. Boom. And now look at here. So now look at here. She, there was during the extubation, she came right back in, spontaneously breathing. That's how I do it. Look, you can see the bag, she's moving. Nice air, nice volume. So as I reviewed that, I just want to let you guys know that I did discontinue her nitrous in preparation of that. It didn't show on the feed, but it was 100% O2. One other thing I wanted you guys to notice is that when I extubated her with the LMA, she was very high. She was up in my personal workspace. That way, if I have any airway management issues, I can address them without having to deal with the bed and stuff like that. That's bad policy.